I'm very, very pleased to be here. Let me just see if I can get this to work. Yeah. It's really going to be a gallop through my career of the last 24 years, beginning in the early 90s when I came back to midwifery after doing a degree, and I really didn't want to come back to midwifery, but I owed so much money. And actually it was quite interesting because the more you owe, the easier it gets, because if you can't pay back £5,000, you can't pay back 10. So that was quite interesting. So I came back to I came back to St Mary's in September 1992, got involved very shortly afterwards with Manchester Action on Street Health. It's their 25th anniversary today. Sorry, my voice is shaking a bit. I'm trying to speak very quickly, but not too quickly. Okay, so got involved with MASH as a volunteer for women working on the street level, most of them heavy drug users and drinking a lot of alcohol. But as a volunteer, I couldn't deliver any care as a midwife or nursing, etc., etc. And it was very hard, for in those days when women arrived in labour, that was the first time we'd ever really seen them. Basically because when they came to the hospital, they were treated so badly in the attitudes of staff. All their babies were taken to special care and never seen again, and social services were automatically involved. Anyway, what happened then was to try and actually get together a business case to, I saw a gap. How could we deliver care? I mean, research-based evidence is absolutely vital, but you don't need research-based evidence to treat people with respect and dignity, and that's to this very day. So, it took about 3 years in the opposition of the head of midwifery. It was going to be over her dead body that we created this role, and I thought, well, if that's what it takes. And it was actually funding from the drug service, and St Mary's were embarrassed into meeting half of that. And I based myself on the drug service. And it was a very interesting journey. I've had plenty of battles to fight along the way, as I'm sure you remember, John. And I'll finish my story with my most recent one. Came into the post in 1995, set myself up in the drug service, which was quite a sort of an amazing reaction. What on earth has a midwife got to do with drug services? In those days, the safeguarding issues were largely absent, as was in terms of healthcare for women. Sometimes you wouldn't even know if there were children in the family, but that was a long time ago. So fast forward, I suppose, the job just took off. It took a citywide response so that there would be equity of access to the 3 maternity hospitals. And including my work, I have to be careful how I phrase this, my work in the red light district in my job description. And I sort of made it up as I went along. And of course, drug misuse does not sit in isolation. And so it uncovered an awful lot of issues that we're in this room we're all very familiar with. So, fast forward, I suppose, to 1999-2000, and do you remember Tony Blair? He suddenly announced at some conference we were going to create midwifery and nursing consultants so that you'd remain clinically focused, but not up in the sort of ivory towers of bed management. And the Royal College of Midwives had suggested my role would be ripe in terms of developing it further, because it had become completely unmanageable with the hundreds and hundreds I had in my caseload. And certainly I wasn't doing antenatal and postnatal care routinely, because my job I felt was to develop the workforce and challenge their attitudes. Comments like, I'm not judgmental. You know what's coming next, don't you? But that woman's riffraff. Comments like that you had to sort of challenge in a way that didn't involve punching them in the face, but turn it into a learning experience. So anyway, again, the head of midwifery, it was going to be over her dead body. I would be a consultant midwife. Who did I effing think I was, quote unquote? And it had nothing to do with public health as far as she was concerned. So it was the Health Action Zone of Manchester, Salford and Trafford put up the money, and they leapfrogged over the head of midwifery and went to the chief exec who supported it. And I was appointed in 2001. based myself in the Zion Community Resource Centre that had just opened. And I wanted, in the light of this particular head of midwifery, I wanted a plaque on my door that said Consultant Midwife, ha, ha, ha. And, you know, just before I forget to tell you this good bit, that September she was suspended for bullying and harassment, was never seen again. So, we decided to call the service Manchester Specialist Midwifery Service, and there's 3 maternity hospitals. It's just really to give you a flavour of developing service right across. I'm not going to go into any details of the research we carried out or the details of treatment, but it's just really about integrated services. And the post we developed in Manchester was the very first. There was great work by Calcina here in Liverpool, but our post was the first jointly funded in the whole of the UK, and it's now standard practice in all maternity services. And indeed, I was involved in a nice publication, the guidelines around social complexities, you know, and we would never have thought that 20 years ago that maternity care and general hospitals would take it seriously. So, of course, all these services were involved. We also set up, we were one of the first in the country to introduce HIV testing. I trained as an HIV counsellor, and to introduce it in 1992. I did the course, and then we introduced HIV testing in pregnancy in 99. And you can imagine the challenges that threw up with the staff. That was I could talk about that all day. And I also went in and out of the prison setting, and sat on some of the prison groups as well in terms of care for women in prison. And my master's degree was focused on the partnership between the NHS and prison health care and what would happen within the NHS setting. Black Health Agency, LGBT Foundation, Women's Aid, MARAC, Multi-Agency Risk Assessment Conference. Most of you will be aware of MARAC. I also sat in the domestic homicide reviews in Manchester. As you can see, it's not a lot to do with babies, really, is it? Of course, the police, we work very closely with the police, which, of course, again, 20 years ago, you wouldn't probably sit at the same table as them, whereas we were all singing from the same song sheet, albeit sometimes with different tunes. And, of course, children and adult social care, very important. So talking taboos, all the things, and training was a big part of my role in terms of trying to challenge the staff attitudes and get them on board, and, you know, to get them to see the women as women first, not as drug users or prostitutes or whatever. Again, alcohol use versus abuse, drug use, all of those things. I'm feeling tired at everything we had to do to get things moving, really. Again, prostitution, sex work. And one thing I always find when, you know, I actually saw on the delivery board one night, it said prostitute, you know, next to her name. And, you know, it's quite interesting to see staff's reactions. It said, you know, every punter is someone's son and someone's husband and someone's GP. I said, maybe you'd like to make a telephone call home and see if he's at home when he says he is. You know, and it got them thinking in a way that they could actually try and treat them with respect and dignity. There's still pockets that still need addressing. Can we drink of water on that? Yes, please. Yeah, thanks. I haven't talked so much so fast for ages. And of course, I started doing training. There was a conference in Chester, John, all those years ago that you said, why don't you come and do some training for HIT? And here I am today. Thanks very much. Right, I'm all right, don't worry, I'll finish on time, because I want to leave you with quite a lot of questions and food for thought. Again, we've developed over the years a perinatal mental health clinic that runs weekly in the antenatal clinic at St Mary's, and also for the last 8 years we've had an independent domestic violence advocate based in the antenatal clinic full-time, because I was lead for domestic violence and abuse and FGM latterly. More taboos, all the things that have huge impact on maternity care and gynecological care. You know, I remember seeing in the notes as well, I used to frequently review the notes where it would say, hysterical during vaginal examination, uncooperative during vaginal examination. And you'd say, why do you think that might be? And it had never, ever crossed their mind. It does now. Trafficking, again, we've picked up just in the last year from 0 women identified, young women, to about 28 in the first 6 months who was picked up by the community midwives because they were in relationships with mainly older men, and the only way they could communicate was through translation apps. And it ended up in a lot of women being rescued and a lot of men being jailed, thankfully. So again, things are evolving all the time. I mean, sharing information, that used to be really difficult. Nobody would share information, or, you know, it's confidential. And to me, confidentiality is often a way of not addressing difficult issues. And even with the women, and, you know, being absolute, the women and their families, I would say, we've a range of choices here and they're all shite. And they all involve the social worker. Which shall we go with? And they appreciated that because we could sit down and make a plan that they were involved in working with. And of course, it involves safeguarding and child protection. But that's to try and keep the family together, not to automatically remove the babies. That's what used to happen. And many, I mean, society sets up women, you know, to be mothers. Still in these days, oh, are you having a baby? Are you having another one? You know, so you're defined by motherhood. We're all defined by motherhood because everybody in this room had a mother at some stage. I mean, I know when I was pregnant, somebody said to me, oh, whose is it? So I was actually rather impressed by my rapid, witty remark. I said, well, it's mine, actually. I said, but do make a list of questions out and I'll go through them with you. Needless to say, they didn't. And of course, we've a lot of ethical and moral dilemmas, especially in the early days of HIV, where women didn't want their partners to know. And how do we manage that? It's changed dramatically over the years, but still come up with more moral dilemmas. I mean, I had the unenviable task of informing 2 women some time ago, not at the same time, but they'd specifically declined to be tested for HIV, and it was done anyway. Not through malice, but just a lab error. So I had to actually tell them they were positive when they hadn't wanted the test. But, you know, they didn't sue, so I must have done something right. Okay. So this is a book that I used extensively in some of my training issues, and a bit of poetic license about some of the questions that we have to deal with in terms of back to the ethical dilemmas and how we manage a very vulnerable population. And what you want is women to turn up to maternity care. Now they do, even when they're not pregnant. You know, again, people say, how do you measure your outcomes? I say, well, you know, I'm not really sure because it's a difficult one to demonstrate. But when women say, I go there because they don't treat me like shite anymore, that's good enough for me, you know. I don't know how you put that in a paper, but I maybe don't use quite such flowery language. So some of these parenting assessments as part, within this book, some of the questions. So I'm not going to answer them, it's just for you to be thinking about, and I'm sure you've often thought of some of these things yourself, and it's all discussed with, and anything that I did, the policies, the guidelines, the leaflets, the women and their families I worked with were all involved in it. So, what else is going on makes us think in terms of it doesn't sit in isolation. Many of the families I work with, and not just the people who are in drug treatment services or not, there's a lot of domestic abuse right across the strata within, and we are ideally placed within the maternity service to pick it up and try and assess the risks. Again, how does parenting capacity become impaired in these circumstances? Again, and what's the child's capacity to tolerate the changed and often detrimental care they may receive? And of course, many of the population I were working with come from very traumatic, damaged backgrounds, complex issues when they were growing up, and abuse. So really sometimes I'm not talking to 22-year-old Sandra, it's 12-year-old Sandra who was taken from a home of abuse and put into a care system that didn't care for her, and she's been frozen in time. I'm nearly finishing up. And what about their commitment? The parents' commitment to maintaining the family, their own health and emotional resources. I mean, this could apply to anybody. What about your ability to communicate and work together? And of course, as I've alluded to, a history of violence or conflict. So again, about neglect, maltreatment, emotionally abused, socially isolated, bullied, stigmatized when they go to school. And what's the child's total experience? And what are the protective factors? And is the parent emotionally available? And again, very importantly, particularly in the perinatal mental health field, we do hear of tragedies where the women become very, very ill and feel that the only safe place for their child to be is to be dead. You know, and that's work very closely with the perinatal psychiatrist. And we're lucky enough in Manchester to be one of the very few mother and baby units. So challenges for professionals and volunteers and all other agencies that we work across the city with. How can these risks be assessed and how can they be managed? Who decides? This is one that always throws up a good discussion. Who decides when they become acceptable? It's easier to say, oh, it's unacceptable, isn't it? Rather than leave you in that dilemma. What shall we do? And of course, what services need to be available to meet the needs of both adults and children in these circumstances? How can they communicate? I think face-to-face is always very important. What training? Well, HIT's been the pioneer in the field of training for a long, long time, and I've been really privileged to be part of that, and for Pat to have twisted my arm up my back to get back up after a bit of a break in speaking. And what supervision and support is available? Because one of my sort of passions is around vicarious trauma in the clinical setting. And I think that's really important to realise, because many of us, I include myself in this, may have histories that inform our work. You don't necessarily go around disclosing what may have happened to all of us, but it can impact on your work with very sometimes challenging people, and it's really important that, and again, can impact on your personal and professional boundaries and may lead to unsafe practice and service delivery. So that's again a very interesting side of work for me. So when you see the adult in front of you, I always say you need to see the child, and I don't particularly mean the child or the children next to them, see the child within. Voices from within. And this is just a saying from one of Maya Angelou's books: how is it possible to convince a child of his or her own worth after removing him from a home which is said to be unworthy, but where he identifies? And now I'm going to just finish off. I'll just finish off by telling you, where are we now in Manchester? It's not a happy ending, really. We moved into the hospital in October 15 to save the City Council money. I hadn't been based in a hospital setting full-time for over 20 years. And then 3 months later, the City Council pulled all the funding for the citywide service from the team of 7. My funding wasn't affected, but I wasn't naive enough to think that they wouldn't start tinkering with my job description, which they did, and decided, on top of everything else that I've described to you, they decided I'd carry a caseload of 60 women with the most complex problems and do all their antenatal and postnatal care. I thought, I don't think so. My post was then, they finally agreed. They said it wasn't a redundancy situation, but I thought, we'll discuss that in court, actually. You know, as somebody said, I said, I'm not going without a fight, and somebody very senior said, well, I wouldn't have expected any less, would you, Faye? So my post was made redundant last January, and we only cater now for the women in St Mary's. And it's just heartbreaking, you know, to save money, and very short-sighted, I would say. Anyway, of course, it wasn't about me. It was about the job and to save money, but that's a different discussion in itself. But just on a very cheerful note, so I'm now a sort of lady of leisure, but I'm keeping myself busy. And now, let's see what mood you're in after this morning's session. What does that say? Opportunity. Hands up who says opportunity is nowhere. Oh, very pessimistic. Well, I think opportunity is now here, and certainly that's what today's all about. So Thank you very much.